Hi, welcome everybody to the part 3 of the Preparing for SJT series, top tips for medical legal questions in the SJT. Really happy to have Dr. Alvin Gardner here teaching us today. So if you can move on to the next slide. So yeah, just introducing Dr. Gardner. He's currently an F1 doctor working at the William Harvey Hospital, and he's very unique because not only did he have a medical degree, he also had a master's degree in healthcare ethics and law. So we can't think of a better person to be teaching this series. And just to talk about our team, we're the final year series of Mind the Bleep. And I'm Janice. I'm the lead for the final year series. And if Dr. Gardner could kindly move on to the Wesleyan slide. So this is our team. We have Salmia Balamrit, our leads for the Kiel Medical Education Society. They do a lot in the backstage. And of course, Akash, our founder, and Dr. Patrician, who's the lead for prescribing PSA series. She'll be teaching the PSA part 5 tomorrow on calculation. So hope to see you there. And we're really happy to be partnered with Wesleyan, who provides excellent advice for F1s, not only in your career, but also in your finances and well-being. And a friendly reminder that MDU is also our sponsor. And just to let you know about the F1 membership and the free gifts, which are very useful for your first on-call shift as an F1. And I'll now give the stage to Dr. Alvin Gardner.
Okay, thank you very much, Janice. Thank you very much for such a lovely introduction. Yeah, thank you very much for all attending. I hope you aren't feeling too stressed out about the SJT. I know it can be quite a worrying prospect for a lot of people. Trust me, you'll do just fine. And yeah, I think what I'd like to do today is guide you through some basic legal principles that are present within the SJT questions, as well as sort of relate them to how you might work as an F1. And some of them can be useful for MCQs as well. So it's a sort of quite a all-round holistic approach. Okay, so just going to read out some ILOs that I hope we'll be achieving by the end. So understand the principles of consent, capacity, confidentiality and negligence, as well as we'll be covering a small bit on prescription error and DNACPR at the end as well. Understand the legal implications of consent, capacity, confidentiality and negligence in our roles as F1s, because you won't really notice it, but it's omnipresent. You'll be sort of, well, unknowingly completing these tasks. So it's quite important to have a strong understanding of this. Recognize the legal themes in SJT questions, and finally to incorporate legal principles into answering SJT-style questions as well. So in terms of the format of this, I'm just going to go through each of the legal principles, have some questions that are related to it, and we'll talk through it. And there'll be a chance, a minute at a time, for people to answer via polls, as far as I'm aware. That's correct, right? Lovely. Okay. So starting with the consent. So what is consent? In a purely medical term, medical sort of meaning, it's the giving of permission to an individual before they receive any type of medical treatment, test or examination. Now, obviously, that's quite a specific definition. Consent is actually a lot more broad and actually encompasses every kind of human action that ever occurs, or any kind of human transaction. Importantly, these can be subdivided into 3 categories. So verbal consent, so that's pretty self-explanatory. When we talk to patients, consent them for procedures and so on. Written consent, so that might be your consent forms. Importantly, in specialties such as surgery, it's good to distinguish who actually is allowed to fill out those forms. And the last one is non-verbal and implied. It's a bit more subtle and actually leads to more sort of legal confusion. But for an example would be if you were to ask someone that you were going to take a blood test and they were to sort of lift up their arm and show the bare area of skin. Whilst the consent is not written or verbal, it would suggest that they are willing to undertake that blood test, for example. So, importantly, consent has 3 aspects. So it has to be informed. So informed being you have to provide adequate information. Voluntary, meaning free from coercion, and the patient has to have capacity or not. We'll move on to that. All right. So, talking about being informed, what do people think an adequate level of information, or what aspects need to be covered for a patient to be informed? If people post just any suggestions into the messages, that'd be greatly appreciated. I'll see if I can see any of these. Yeah, wonderful. So risks and benefits, very important. Yeah, risk, complications. Actually, yeah, complications as well. So yeah, lovely. Understand, retain, weigh up, and repeat. So that's actually more to do with the capacity side, but it is something that you would be assessing as you're explaining this all to them. Yeah, other options, that's important. So the case we cover next actually talks about alternative treatment options and why they are so important to be offered. Yeah, reason, so why it needs to be done, and so on. Yeah, thank you very much for all your responses. That was very, lovely engagement. So yeah, so these are a couple. So the reason for it, available treatment options. So just because you think that this must be best for the patient doesn't mean it necessarily will be for them. You need to give them the whole array. Risks and benefits, yeah, fair enough. That's going to be just nice. That will allow them to balance their decision and make an informed choice. Prognosis of disease intervention. And it is also important to give the clinician recommendation as well. I mean, we are the experts, and so it weighs a lot into what a person might want to do with their decision and so on. Course of treatment, yeah, and consequences of no treatment. In many ways, whilst we might not determine that as an actual form of treatment, sort of conservatively managing people can actually be the best way. Lovely. So I'm just going to briefly describe the landmark case of Montgomery versus Lanarkshire, which is embedded in the GMC best practice principles as well. So to briefly describe it, we have a pregnant lady, Nadine Montgomery, who has a background of type 1 diabetes. She opts for a natural birth, having been consented by her obstetrician. However, during labour, there are some complications and shoulder dystocia occurs. And subsequently, the baby has irreversible hypoxic brain damage. Now, Nadine Montgomery took the trust to court over the fact that had she been told of other alternative options, she would have chosen. So had she been told the risk of shoulder dystocia and the effect on the baby, she would have opted for an elective cesarean section. And the courts ruled in her favour. And I guess a brief outline of the outcomes from the decision here. So yes, it actually relates a bit to what we just discussed before. So should be notified of risk and benefit of the treatment being offered, as well as all alternative management options. It also defined the concept of material risk. So a reasonable patient in the patient's position would likely attach significance to, or risk from the perspective as a clinician knew or should know the patient would have attached significance to. Very wordy, however, the idea being given the patient's background, it should be inferred what might be most significant and what might significantly influence their decision. Otherwise, patients should be supported to make autonomous decision. So that's just giving them the right information. So that reflects this whole shared decision-making model that the NHS is moving towards. So away from this sort of paternalistic view of this is the correct medical management, you must do this, and so on. And yeah, so the last one highlights the importance of autonomy and how that reflects in our sort of pillars, ethical principles. Sorry, I need to use my mouse. Oh yes, also, so shift from percentage risk as well. So just because it's uncommon or rare doesn't mean that it shouldn't be included. So I think the risk of shoulder dystocia was actually 1%, and that's why it was deemed that it shouldn't be communicated. However, as the risks are so significant, the court's deemed that it should. So, for example, that's why I guess one recent example is the risk of anesthesia. And the reason why people are persuaded against it is because there is still a 1 in 100,000 risk of death, even if you are a healthy male or female. And so just because it's 0.01% doesn't mean that it shouldn't be mentioned. And yeah, lastly, answer questions with honesty. So be frank. Don't bombard patients with information. They're not going to get it. And it's just a pointless exercise. And yeah, it's important to maintain this partnership model. Lovely. So, second aspect, voluntariness. So voluntariness is essentially the state of being, sort of having no coercion. Scratch that. So a voluntary decision is essentially one that is free of coercion, manipulation, or deceit. And this actually reflects in one of our pillars of bioethics. You may have heard of these 4 principles before. It's actually might even be included in the GMC best practice literature, but it's beneficence, non-maleficence, autonomy, and justice. So briefly, beneficence is doing good for the patient, non-maleficence is do no harm, autonomy, encouraging personal choice, and justice is doing what is, I guess, virtuous and right. Okay. And the third part, so this is the main part of consent that actually relates more towards the SJT questions and I guess application in your jobs as F1s. So Mental Capacity Act 2005 is it's a legal framework and set of principles for predominantly healthcare professionals, but not strictly, and affects those that are 16 and above. There's separate legislation and separate stipulations for those that are under that we won't be covering today. And so it essentially helps us guide us make decisions on those who are lacking in capacity and ensures that they have decisions made in their best interest and they can enjoy as high a quality of life. So you will judge capacity regularly as an F1. I'm sure you may have, as medical students, seen those patients on your wards that have been deemed lacking in capacity and how decision-making processes might how decision-making processes might be different. So once again, another quick question to you all. So what kinds of examples of people lack capacity? Or what examples can you think of? Oh yeah, feel free to post in the chat, by the way. Yeah, good. Delirium. There's Alzheimer's. Yeah. Coma. Yeah, coma, unconscious. So unconscious can cover quite a few things, I guess. Can be obviously comatose, could be intoxicated, inebriated, all these things. But any sort of medical condition that dementia, nice, and it's decision specific, good. So it's very time specific and decision specific. So what's very important is that just because someone has a background of, let's say, dementia, yes, fair enough, they may lack capacity in certain situations. It doesn't necessitate that they always will. So it's a time-specific exercise. So, thank you very much for your input there. So yeah, aims of the Mental Capacity Act, quite succinctly put, is to protect those who lack capacity and help them to partake in decisions that affect them as practically as possible. So as feasibly as possible. So we're going to go through the 5 main principles of the Mental Capacity Act. If any of those want to do any further reading, there is some lovely literature of the Code of Practice. It's lengthy. It's about 300 pages long, so I wouldn't be offended if you didn't read through that. But yeah, I'll provide a brief overview of what's involved. So, principle 1, patient must be assumed to have capacity unless it is established that the patient lacks capacity. I'm sure everyone's heard of that before. So the assumption that the patient is able to make decisions is paramount. So yeah, ignoring any kind of medical conditions that may cause mental impairment must be neglected. Well, not neglected, but sort of, and the assumption is that they have capacity. And the reason why we go with that approach is it ensures that we are upholding autonomy as the number one principle. And that's the guiding principle for any decision. Just realize I'm probably going to need to speed up a bit. Okay, so a person is not to be treated as unable to make a decision unless all practical steps to help him to do so have been taken without success. So the idea behind this, so that's section 1.3. So you want to provide as much adequate information and in an appropriate manner as well. So if they prefer, for example, pictorial cues, or potentially language might be a barrier as well. I once had a psychiatric patient that if you talk to them, you would think, yeah, I mean, there was no way to get through to them. However, they would speak in Italian to one of their cousins, and that's how we would communicate with them. And so that's how we maintained, well, best interests framework for them. So yeah, aids, family, as well as environment. So they may benefit from maybe earlier on in the day they might be better. In certain environments, or like rooms, they might be better, and so on. You get the gist. A person is not to be treated as unable to make a decision merely because he makes an unwise decision, section 1.4. So this is the principle of a patient's right to refuse treatment. So we have the tendency to think that medical treatment is going to be the best for them. That's because we're geared as, well, people versed in medicine, that's correct. When in reality, it may actually not reflect patient's values or beliefs. And so we adopt a 2-stage capacity test. So the first part being the diagnostic test. So that's the time-specific part that someone mentioned earlier, so decision-specific and time-specific. So that's a time-specific decision determining whether there is any kind of mental impairment of the mind that might be impacting capacity. Then the functional test is what you probably all know of. So it's your 4, wait just a second. So understand, retain, weigh up, communicate. So if there's an impairment in any of those, they are deemed to be lacking in capacity. Lacking capacity. Okay, and briefly, principle 4 and 5. So an act done, decision made under this act for or on behalf of a person who lacks capacity must be done or made in his best interests. So, yeah, encourage patient participation as practically as possible. So we want them to be involved as much as possible in the decision-making process. Check for any past and present wishes as well, whether they be documented, whether they may be verbal, so you may have heard them previously on the wards mention this when they did have capacity, and other individuals that can be accessed, so carers, family members, a deputy of the court. That's rare these days, but you probably won't ever see that. Last thing, power of attorneys. They're also very important in decision making as well. Important to consider LPAs. There's two types, one for financial decisions and one for healthcare decisions. So make sure you're consulting the right one for the right decisions. And the last principle is, okay, before that's done, all the decision made, regard must be had to whether the purpose for which it is needed can be effectively achieved in a way that is less restrictive of the patient's rights and freedoms. Essentially, this is the concept of least restrictive option. So we want to, I guess, cultivate a reality for them that is not going to impact too much on their freedoms, and they're able to still make, well, decisions as much as possible. Yeah. Lovely. That one won't come up in SJT, I doubt it. Okay, so lastly, before we move on to our questions, I know I've been talking for a while, consent in emergency. There are certain scenarios where it is more practical and less harmful if consent were to be breached. And so a couple of examples that actually may come up in SJT style questions is risk to public health. So any kind of notifiable diseases, rabies, cholera, TB. Severe mental health, so application of MHA, so section 2, section 3, if you're a clinician, so that's going to be 28 days, 6 months. Section 5 if you're a nurse, and 136 if you are the police force. But the idea is that you're being detained. Emergency treatment where patients incapacitated. If someone's completely intoxicated, overdose, very inebriated, you usually just act in the best interest because you know you're not going to get anything out of them, usually. And additional emergency procedures during surgical intervention. Any kind of complication that ensues or any incidental findings that, actually incidental findings, that's a bit of a grey area, but any complications, you're not going to try and wake the patient up and ask them, mate, do you mind if we stop this hemorrhage, for example? That's in the best interest to keep going with that, despite it not being consented for. The last one was just an interesting one that I found. So under the National Assistance Act 1948, severely ill patients in unhygienic conditions can be detained as part of their best interest framework. So, the part you've all been waiting for. Questions. So, I'm sure you've all been practicing these questions a fair bit. I believe your exams are next week, from what I understand. So, hopefully you probably have seen these before. These are all taken from the SJT practice questions. So, if I give you a minute, unfortunately we can't on the screen, but I'm just going to tell you when we have 30 seconds left. So if we start, and there's going to be a poll. Go.
Sure. So we've got 73 responses. The most popular choice is AEDCB.
Someone's been revising hard. So yeah, AEDCB is in fact the correct answer. So the legal principle here is, I guess, the functional test of the MCA, isn't it? So he doesn't understand fully what might be going on. So there might be some impairment in potentially his consent. So the idea is you're meant to respond to that and rectify that. And so as SJT classically loves it when you directly respond to that. So that's why A is going to be at the start. Inform the specialty trainee that the patient would like further clarification. of the operation. So that's also going to be addressing potentially what might be lacking in the patient's thinking, and also if it's within, so the specialty trainee is within the team. I can't remember if so the speciality trainee actually obtained the consent, so yes, they're going to be in the best position. Classically, B is going to be wrong because there's no real grounds to actually withdraw consent as such. And what's left? D and C. So inform your consultant. So classic. So yeah, still keeping it within the team, directly contacting your team, as opposed to asking the nurse. They never like that because it's delegating responsibility when it's actually your responsibility. All right.
So someone is asking, why doesn't E come first? Because I think they're implying that the specialty trainee knows more about the procedure.
Yeah, of course, but the speciality trainee might not be present at the time. Whilst you're there, I mean, it's a minor procedure. You are able to ascertain their understanding. That's it could be something quite minor that could be rectified by yourself, and so that's why I'd personally say it's appropriate. Also, if you don't need to bother your speciality training, don't bother them. Right?
Yeah.
Lovely. Okay. Question 2.
So there are two answers that are most popular. The most popular one is DACBE. The second most popular one is DBCAE. So it's the B and the A that people are a bit unsure.
D and A. Okay, gotcha. So I personally think that this can. Oh, I'll go into the next slide. This can personally be split into 2 sets. So I'd group D, A, and C together, and then B and E. The reason for this is because at the end of the primary concern is of the family. So D, C, and A directly will address the family's concerns. Asking a consultant for his reasons requesting a post-mortem is kind of just sidelining the family. So let me just go to here. So primary issue, so family's concern. So once again, explore the family's concern with them. If you're directly exploring concerns, it's usually going to be top. So DACBE. So during the ward round, informed consent totally did not want. Oh wait, sorry, this is a different question. So D. Refer the family's request back to your consultant. Ask them to speak again, because yeah, it was a consultant-led decision to request the post-mortem. And also, if it's a senior colleague, is also going to be in a not as good as the consultant to address these concerns, but is inevitably within the team and should know the rationale behind this. And E, reassure the family that post-mortems are standard practice in situations like these. That's actually the no, absolutely not. And there is actually some case law into it, and the Alder Hay inquiry in 1999 that actually led to the establishment or helped establish some of the principles in the Tissue Act 2004. Essentially, it was found that the Alder Hay Trust were holding on to, so post-mortem were holding on to organs of babies without actually consenting the parents. And one mother that decided to investigate further found that her child's body had been disposed of, but the heart still existed somewhere within the hospital, and so that's why. Okay, so quickly, question 3, please. Okay, so a bit of consensus.
So 36 responses. We've got a majority picking A, E, B, C, D. And going in second is D, E, C, A, B.
Okay, D, E, C, A, B. Okay, I got it. 30%. So yeah. So A, E, B, B, C, D. So there's an obvious one that shouldn't go anywhere near the start, and that's going to be D. So you're essentially denying. So he has full capacity. He can make his own decisions. You're infantilizing the patient and being quite condescending by telling him this is not the right option. D definitely goes last. What's important to consider with this is who's actually. During the ward round, a former consultant told you he did not want any invasive procedures to be conducted. During the ward round, asked Mr. Okay, yeah. So it's much better to tell the consultant that this is the case. I mean, you're directly passing the information on to the primary responsible person, whilst E is a bit more confrontational. It's a bit passag during the ward round to mention to the patient that without actually directly consulting the consultant is the reason why it goes A, then E. B still addresses it because you're still talking to the consultant that is in charge of those invasive procedures, and seek advice on what to do from another senior doctor. It's another senior doctor, so they're likely not going to be part of their care. So that's why that's the order. Importantly, the reason why it's so important, why you need to relay this information to the consultant is that for any kind of invasive procedure without consent, that's actually battery. So that's the unsolicited unsolicited use or invasion into someone's personal self as such. So it's similar to assault, but with battery there has to be some kind of consequence. So there has to be some damage incurred. Okay, cool. So 25 minutes left. Lovely. I'm going to try and whiz through this part in 5 minutes, and then we'll have enough time for the questions. So confidentiality. So obligation for doctors not to disclose private information passed on from patients. And a breach of confidentiality is actually defined as misuse of private information. So anything, that may be uttered within a private setting, that is all count, and purposefully using that or misusing that will count as a breach of confidentiality. And the common law, as well as jurisdiction, identifies three main ways of enhancing confidentiality. That's protect, inform, provide choice. Improve is a bit of a sort of wishy-washy one. Yes, fair enough. We should always be proactively trying to improve, protect, inform, and provide choice. That is the basic part. And so why do we need to maintain confidentiality? Why is it so crucial within our profession? Well, one of the lords in Z versus Finland opined this. So respecting the health data is a vital principle in the legal system of all the contracting parties to the convention. It is crucial not only to respect the sense of privacy of a patient, but also to preserve his or her confidence in the medical profession and in the health service in general. So essentially what this is getting to is by maintaining confidentiality between the doctor and patient, the patient maintains trust and therefore can speak plainly. So if they know that their information is not going to be shared about to third parties, obviously it can be within certain medical teams, then they can confidently come and approach you, and this leads to much better outcomes, because if there's a sort of relative idea to confidentiality, you can sort of you can say what you want to, I don't know, mate down the pub or something like that. It's not going to fly. And so what's important is this is a legal obligation for everyone within the healthcare setting. So if you notice any So it's your responsibility to, well, firstly, not breach, as well as if you see potentially misuse of private information, it is also your responsibility to address that, because it reflects on yourself as well as a profession. NHS was one. All right. So there's a couple of things. The legal base of confidentiality, common law. So Article 8 and 10 of the European Convention of Human Rights, they're the conflicting ones. So one is the right to privacy and to self. So that's number 8. That's 8, and 10 is the freedom of expression. So they're the slightly confounding two. So one is the private interest, whilst one is the public interest, and it's the constant battle between the two that leads to whether you maintain confidentiality or whether you breach confidentiality. Data Protection Act, yeah, that's just to do with computerized information, and as you may know, there are professional codes of conduct, so NHS codes of practice, and the GMC best practice that you guys would have been combing through past couple of weeks. Lovely. Okay. Skip that. So, justifying disclosure. So this is the balancing between the public and the private interest. So where information is found to be private and confidential, any non-consensual disclosure requires justification in the public interest. So there are certain times when individuals do consent to their data being used by us, and so that's involved in sort of clinical governance, clinical audits, but they do have to be notified. So if I think there was an SJT question in paper 1 about use of information in a clinical audit and how it has to be actually communicated to the patient, and their concerns have to be protected. And the Public Health Act, so relating back to how we talked about how sometimes we can breach consent. In a similar way, we can breach confidentiality if there's going to be a public health risk, for example. HIV, TB, all these notifiable diseases. Okay, so if we do another minute for this.
A majority picked D, A, C, B, E.
Lovely, that is the correct answer. So this one is a bit, so there are two that should be popping out to you and you thinking, okay, this is number 1 and this is number 5. Obviously, people have different tactics, but I quite like to identify the one that's definitely correct and one that's definitely not, and put them in and then sort of muddle up the middle 3. So the patient's right to confidentiality is going to be the most important. It's embedded in law, it's embedded in code of practice. It is what we're here to protect in order to maintain, as we said, that professional relationship and maintain trust in the profession. And so therefore, conversely, the fact that this conversation is likely to be time consuming and therefore you may leave late kind of completely disregards their concerns and the legal principles that we're trying to protect. Okay. So DACBE, wasn't it? So with this question, it's quite important that you don't know the patient. Now, that's why the risk of miscommunication with the family is very important, because this could result in further distress and actually providing completely incorrect information. So you're not acting in honesty. So that goes against some some principles. And oh yeah, so then the conflict with James, you should get on with the rest of your colleagues. However, that shouldn't surpass the fact that you're trying to concentrate. So C still is more patient-centered, it's more family-centered. So always think the patient comes first with these questions. Lovely. Okay, so number 5, go. Also, if there are any questions, please post in the chat. I'll try my best to answer them.
So majority picked B, D, A, C, E. The second most popular option is D, A, B, CE. So it's the D and the B that people are juggling between.
D and B, okay. Well, I think the principle that we're juggling with here is confidentiality, isn't it? I think what's important is you have to establish that you are not you don't have the right to breach confidentiality. So I think that's the first step. So was it B? Tell Mr. Matthews that you'd like to obtain Mrs. Matthews' permission to speak to her first. Yeah, because that could just easily be resolved with yes. Okay, thank you. I'm going to pass on the information. And you're respecting confidentiality. And I think that's the only one that outrightly does. So tell Mr. Matthews that you're currently investigating Mrs. Matthews' abdominal pain. You are actually telling him the truth. You're telling him what he knows. I think what's important is actually he's made aware of it in the question, isn't he? So he's admitted for investigation of abdominal pain, which her husband is aware of. So you are being deceitful, but you are providing accurate information, and you're still maintaining confidentiality. DACE. Tell Mr. Matthews that he will need to speak to Mrs. Matthews directly about her condition. Yeah, appropriate. Less appropriate than actually asking her, but it's still addressing the fact that it's her permission that needs to be obtained. E. Okay, I mean now it's just we know that E is last, so C is going to be fourth. Inform Mr. Matthews that Mrs. Matthews had a urine test with a positive result. Nope. That will actually get you in a tricky situation, and you may potentially be sued by Mrs. Matthews. You have no idea what might be going on at home. There might be a very, very valid reason for her to be withholding that information. And so you would not be, you'd be protected by the MDU if you get obviously your F1, the packet mentioned at the start, and any kind of medical protection. But yeah, otherwise, would not be fine. So question 6. Okay.
So majority picked C, D, A, E, B.
Okay, lovely. So C, D, A, E, B. Okay, so the important part is this. The top one is obviously going to be establishing. So similar to the one, I think it was question 4, but you have to establish that you aren't allowed to breach confidentiality. That is incorrect. So you have to establish the impermissibility of breaching confidentiality. So that's why C would come first. Okay, yeah, so senior colleague, so with regards to actually breaking bad, you can break bad news, but a cancer diagnosis, unfortunately, has to be delivered by a consultant, potentially a registrar, I'm not entirely sure. If you do it, that is a breach of code of practice. So that's why we would have D next. Exploring concerns, exploring what Suzanne thinks is always a good idea. But if I remember correctly, so I don't think this actually addresses the fact that there's potentially a breach of confidentiality. B, similar to question 4, that's a complete breach of confidentiality without justification or clear justification. So there'd be legal implications of that, and therefore E would come second last. Lovely. 7, go. 1 minute.
So with regards to the results of the poll, majority picked A, B, E, D, C.
A, B, E, D, C. Yes, correct. Okay, so once again, nice obvious one presenting us as the top option. So that should be A. So I did actually breeze over it, but that's the statute mentioned earlier, the Human Rights Act, Article 8. That is the embodiment to it. You have a right to privacy and it's protected. Nowadays, in post-Brexit days, I'm not entirely sure what's happened to that. It might be converted to the Human Rights Act we previously had, or it might be going through some amalgamation. I think it still does stand though, and the principles definitely do. Okay, so A, B. So B is actually surprisingly important. It's just a more common sense of if there's no room, there's no room. So that would be very important to your decision making. A, B, C. No, wait. So C is definitely last. So the fact that, and so this is a classic one that they might use as well. So the fact that there might be a hospital manager, or it might be the director of the hospital. Just because they don't get preferential treatment. And then you are left with E and D. So when you balance those two, E is going to be more appropriate because it actually looks into the reasoning behind all this. Right? Okay, so 3 more aspects I want to briefly touch on. Okay, I'm just going to rush through this. So clinical negligence, so this is important. This is predominantly what your MDUs actually, well, MDU, these organizations are going to protect you against. So it's failure by a healthcare professional to exercise a reasonable standard of care. It doesn't actually need to be healthcare related, but in this context, we might as well keep it that way. And you could owe a duty of care in many situations. So it might be driving a car. You owe a duty of care to pedestrians and cyclists and so on. So this is a law designed to compensate an individual party injured by another's negligence, and it's made of a 3-part test. This is just, I guess, interesting to know. But so you have to establish whether there was a duty of care owed to the other individual, whether there was an actual breach in that duty, so whether they actually fell. So if it was within medicine, whether your quality of care actually fell below the standard. It has to be established whether, due to that, the damage occurred. And so, interestingly, does a duty of care exist within the law? There is actually no statute. So there is no such thing as a Good Samaritan law. So if someone passes out, drops to the floor next to you, cardiac arrest, you aren't legally going to be brought up for that. However, it is in our GMC best practice, so you will be kicked off the register. So I'm not recommending that you don't attend any cardiac arrest just because you don't want to. Lovely. Interesting. So prescription errors as well for your practice, as well as there's some questions on this as well. It's whoever wrote it. That's important. Just because a nurse said, "Oh, I think they might need this," or "I need some IV fluids," or to be fair, it could be anyone asking it, really. It could be your seniors. It's always important to establish, if you don't know the patient, why they're taking it, because you will bear the legal brunt of it. So yeah, can be both the pharmacist and clinician who signed it, as well as there is actually just to end on a interesting case, Pendergast versus Sam and D. Bad handwriting did actually result in incorrect dosages and incorrect medications being prescribed, and therefore there was a case of I guess it was negligent by having such bad handwriting. Right, time's up.
Mm-hmm. So majority picked A, B, C, D, E.
Nice, thank you very much. And thank God everyone's picking A as the start. So yeah, you need to review the patient dose, especially if she thinks there's a prescription error. That could lead to some disastrous consequences, as you can imagine. I don't know, microgram being milligram, numbers looking slightly differently. We had someone that was given penicillin because someone had obviously, I think 3 times someone had put penicillin in the box of allergies, but someone had then crossed it out, and then someone had written something over it, then was given. Luckily, it wasn't an anaphylactic reaction, so all good. But still, important to consider this. So there are actually 2 themes going through this question. So obviously, you need to establish prescription error. Also, responding to immediate questions and queries as well. So that's actually directly applying yourself to the problem, because there may be something complete going wrong. And so C, attend the theatre to observe the procedure. So this is to do a bit with the medical education. I'm not entirely sure what the guidance is around this, but the correct answer is C. It's never the most important, it's never the least important. However, it is important within your F1 foundation years to seek out training opportunities. So the last two, spend more time with the patient if you want someone to talk to. No, you haven't. You might firstly not be dealing with the urgent thing that he has to say, as well as the prescription error has gone amiss. Take further steps to investigate nurse allegations. Yeah, fair enough. You might get to somewhere, but why do that now? All right. I think there is a last question, but oh no, that was just So gross negligence.
So the results, majority picked B, A, E, C, D.
B, A, E, C, D. Wonderful. Yes. Ah, good. 95% people picking that. Love that. Okay, yeah. Importantly, if you've not put D last, then I feel what we've talked about today has not, got through to you guys. If you prescribe a drug that may potentially cause some form of an allergic reaction, that will result very much in a fitness to practice meeting. That is gross negligence, and you may be seen the GMC tribunal. So please, let's avoid that. Well, to be fair, if it's sort of more minor, it'd be a datix, but it would be detrimental either way. So number one, obviously, directly explain to the locum doctor why you think this is wrong. That's direct. Addressing the situation. So speak with an on-call pharmacist. Pharmacists know a lot, and they will be able to provide information like this for yourself. Sometimes better than people within your team. So the medical management definitely will be better, sort of established by your seniors. But something like a closely related allergic reaction, an on-call pharmacist might be more appropriate. Okay, so speak your concerns with the nurse. So nurses, they always know a lot. So respect your nurses and ask them, because they prescribe everything. They're with them by the bedside all the time. So that's why that comes third. And ask another senior doctor. Ask another senior doctor. They're not going to know anything about the patient. What are you doing? Let's not do that. All right. So yeah, fitness practice, independent. Oh, sorry, I completely. Right, DNACPR. So try and involve as much as possible of the patient. If the DNACPR is signed, don't start DNACPR. If it isn't signed, start CPR, and then maybe start considering it as you go ahead with it. The main principle being start it if it's not there. Because if you wait around, there will be consequences for the patient as well as legally. Okay. Sorry about that. Yeah, also should not be based on the patient's age or condition. I think from a legal point of view, it's actually important to establish whether everyone coming into a hospital should be considered for a DNA CPR. I think that is actually a legal standpoint. And just because you're young and fit doesn't mean that you may want to undergo the horrors or you may deteriorate into such a condition. Okay. Well, that's the end of my talk. Best of luck to all of you. I hope. I'm not sure what new questions or new styles they might be providing this year. But just sit down, relax, and know the format of the test. Know what you're working with, because that's one of the main things people fall down on. Right?
So we've got 3 questions. So because I think last time there was a similar question on prescription, and I think the answer was asking the senior doctor who prescribed the drug before we asked the pharmacist. But I think in this case it's slightly different. I think the students are referring to question 8. Yeah. So this time I think the question is more about prescription review, but last question was about actually the consultant starting the drug. So I would say it's slightly different here. for sure.
Oh wait, so I think I'm slightly misunderstanding the question. So review the patient's dose. So wait, what was the question?
The question was, wouldn't it be better to ask a doctor bracket senior before pharmacist, as they may know more about the clinical indication of the drug? I'm sure we're told that in previous lecture.
Yeah, so it would be in previous lectures, and it very much does depend because clinical indication, yeah, you would be correct, but something like a niche side effect or interactions or so on, that's very much more in the realm of pharmacists.
Oh, I think, sorry to correct myself. Kev is actually referring to question 9.
Oh, right, that makes sense.
Question 9.
Oh wait, no, that is the on-call one. That is on-call pharmacist. Yeah. And also, I think what's important is this is another senior doctor, so it doesn't actually necessitate that they're part of your team who knows them. I think that's they do word things quite weirdly, and that's one of them. So if they said, ask your senior doctor, that would be much higher up.
Yeah, because it's the team's responsibility, basically, for the patient.
Essentially.
Yeah.
And they'll be more well-versed in this.
The on-call pharmacist, I would say, so from my experience at Tommy's, the on-call pharmacists, they often cover a few wards. So what they do is they screen the medication, but the ultimate responsibility would be the medical team on the ward. Yeah, the pharmacist is sort of like acting as a sort of like a barrier, like a safety barrier between you and the patient before the patient get the drug, the nurse dispense the drug. And then there were questions about, apart from female genital mutilation, knife, gun harm, domestic violence, are there any times that you would involve the police as a high priority?
I mean, I suspect the issues. I suspect it's quite an like exhaustive list, but those are the main ones I think of. Oh, yeah, mental health as well. They have a specific section where they can act, so that's section 136. Yeah, sorry, that's all I can unfortunately offer at this point. The other thing is probably won't be coming up in SJT, but there's plenty of extra reading you can do with regards to. Actually, yeah, there definitely should be. If you sort of look into breach of confidentiality and breaches of consent and detainment and so on.
Yeah, I think what happened on our ward is there's a patient who's physically assaulting the other patient, and it actually caused major physical harm, and the police was involved. So I think SJT, that question could potentially come up because it's quite common.
Yeah, I feel there are like 2 questions on that in the past papers, if I remember. Yeah, just don't aggravate and make sure everyone's safe. That's the mainstay. If I remember.
Yeah, that's right.
Lovely.
Let's see, I think, yeah, about the prison guard and police, I don't know too much about this area, but I suppose what I observed is, I think the question, NS, would you mind posting the question again about prison guards?
Okay. I also realize there's quite a few unanswered questions, but I could post my email or something, or if anyone wants to contact me, if they really want to, I can try and come up with a reply. Do you think is that allowed or is that recommended?
If you want me to get the questions and I direct it to you, that's also fine. Either way is fine. Depends on what you prefer.
I think if they contact me, simply because once they leave, we have no idea who asked the questions. So we do that.
That's right.
Cool. So my final question: prison and prisoners. Something along the lines.
Prisoner question was actually about confidentiality. So what are you trying to imply, NS? And whilst we're waiting for NS to expand on the question, Achille has a question about question 6. How advising Suzanne to wait until the meeting is not?
Oh, sorry guys, could you fill out the feedback form? I completely forgot to post it.
Yeah, thank you so much.
Really appreciated. I know how long it is to fill out those forms. I've done medical school as well. Cool. Is she posting?
Let's see.
I can't see anything.
So not yet.
I'll just post my email just to verify your account to join the conversation. Oh, I'm not verified. Janice, would you be able to post my email?
Yep. Which email would you want?
My NHS one, so alvin.gardner@nhs.net.
Yep, alvin.gardner@nhs.net. Yep.
So if anyone is still on this chat, you're more than welcome to drop me an email if you have any further questions. Predominantly legal aspects, please, because as much, and how they relate to SJT questions. Because I'm here as a sort of, I know a bit more about the law as opposed to I'm a master of the SJT as such. But I can still.
So the question 6 is how advising Suzanne to wait until the meeting is not inappropriate.
So can I just ask the question for that question 6? How advising Suzanne to wait until the meeting?
Just wait until the meeting.
I think it's because it's with a different person. I think the consultant is meeting her next week, but you suggest that wait a second. What was the question? 6. Well, confirm results. So that's no. So that's so CD. Yeah, so CD. Yeah, so meeting until the meeting as a senior colleague will be better. Oh, okay, no, it does say advise Suzanne to wait until the meeting as a senior colleague will be better able to explain the results. So this also ties into the fact that they're firstly the most appropriate to deliver that information. From a legal point of view, they're the only ones that should be able to give the information. So you can't break, as well as in terms of code of conduct, you can't be breaking bad news as a junior, or news of the gravitas as cancer. And that's why that's more appropriate than the 3. So exploring, so the other thing is it's all relative. That's the other thing you have to consider. It's all the questions are within this sphere. So you have to compare them against each other as opposed to thinking, because in reality that might actually be quite rude. It's not really addressing her concerns, and she may be quite taken aback by that. But comparing that to the other 3 that come below it, I think that's important to consider. Is that all right?
Sounds good. So I think the email is recorded. And if anyone wants to ask Dr. Gardner more questions about medical law in relation to SJT, more than welcome to email him.
Yeah, I'll be happy to provide a bit more in depth of DNACPR because I very much glossed over that.
Yeah, so Afreen is asking the question about why we asked the pharmacist before the senior doctor. So I can answer that probably. So senior doctor, they could just be a random doctor that has just popped onto the ward to review a patient. So they weren't very specific about who the senior doctor is. Yeah.
So it just says another senior doctor. Your senior doctor would make a difference. They are actively involved in that person's care.
That's right.
All right.
So let me give it a thumbs up. Okay, so right, thank you very much, Dr. Gardner. Yeah, best of luck to everybody.
Yeah, best of luck. Thank you very much for attending. I know I ramble. All right.